When you need to build up your team to handle the growing chaos at work, use Indeed Sponsored Jobs. It gives your job post the boost it needs to be seen and helps reach people with the right skills, certifications, and more. Spend less time searching and more time actually interviewing candidates who check all your boxes. Listeners of this show will get a $75 sponsored job credit at Indeed.com/podcast. That's Indeed.com/podcast. Terms and conditions apply. Need a hiring hero? This is a job for Indeed Sponsored Jobs.
¿Escuchan eso? Es el delicioso encuentro entre un Extra Crispy McCrispy Strip y la cremosa salsa César. Si así suena, solo imagínate cómo sabe. Salsa César, en McDonald's por tiempo limitado. Ba-da-ba-ba-ba.
Welcome to the Dr. Raj Podcast. Today's episode features Everyday Rheum, a guest series hosted by Dr. Michelle Koolaee. She is a board-certified rheumatologist with a direct care practice in Pasadena, California. She trained at the University of Pennsylvania and serves as faculty and educator at Huntington Hospital, an affiliate of Cedars-Sinai. Inspired by the conversations she has with her clients every day, this series brings practical insights in rheumatology to patients and the medical community alike. And now, here's today's episode.
Hi, and welcome to Everyday Rheum, a guest series on the Dr. Raj podcast. Now, this podcast is inspired by real conversations I have with patients and colleagues every day. Our goal is to bring you knowledge, support, and encouragement to help you make your rheumatology decisions and needs with confidence. Today, we're discussing an important topic for many of our patients that are living with chronic pain, and this is the role of pelvic floor physical therapy in evaluating and treating low back, hip, pelvic, and sacroiliac joint pain. I'm excited to welcome Rachel Daof, a PT, who is founder of the Pelvic Model here in Los Angeles. Rachel is a pelvic health physical therapist who is passionate about helping people feel better and understand their bodies and feel more comfortable talking about pelvic health. Rachel has gained extensive experience treating a wide range of pelvic floor conditions in both private practice and hospital-based settings. Her approach combines advanced training, a holistic perspective, and a commitment to help patients feel supported, informed, and hopeful throughout their health journey. Rachel, thank you so much for joining us today.
Yeah, thank you for having me. I'm very excited about this.
Me too. Now, before we get started, Rachel, can you tell our listeners a little bit about yourself and your practice, especially what led you to specialize in pelvic floor physical therapy?
Yeah, so my name is Rachel Daof. I'm a pelvic floor physical therapist. We help people pee, poo, and have sex better, and we're based in Highland Park. So my journey to a pelvic therapist was very interesting. I was actually starting off my professional career as an English as a second language teacher. So it was a journey to the healthcare community. But I was taking care of my grandpa, taking to him to his medical appointments, physical therapy being one of them. And I was looking for a career change at the time, and I just really loved how a profession can encourage people to move better, resume life activities, especially he was an athlete, who developed Parkinson's. So, I then was starting to look into physical therapy as a practice, and in school, obviously, I didn't know what pelvic therapy was, and I had a really great teacher, in anatomy class teaching me about the pelvic floor as she was a pelvic therapist herself, and I just found it so interesting, in even in like, back in my high school days, I was taking courses in college of, like, sexual psychology and women's health, and so the two worlds kind of just, like, magically met each other, like, and here I am just practicing it.
And Rachel, I think you're so smart. You're so meticulous. I think that I'm really excited to pick your brain a little bit today. So let's dive in. Now, some people hear pelvic floor PT and think that it only applies to pregnancy, postpartum, or bladder issues. Can you explain to listeners what is the pelvic floor, what conditions you treat, and who may benefit from seeing a pelvic floor physical therapist?
Yeah, that's a really good question because every single person has a pelvic floor, no matter what genitalia you have. So, the pelvic floor, it surrounds organs. So, for those of you who are looking on the YouTube channel, I have this pelvis over here. Inside of the pelvic bowl, you have your rectum, you have your vaginal canal, and then you have your bladder. And then, similarly, in a male model, we have this one's kinda chunky. We
Mhm,
still have the same organs, bladder, rectum, and then you also have the prostate in here as well.
mhm,
So and if you look inside the pelvic bowl, you can see that all of these muscles surround these organs, so they're very intimately connected. It could so we help people with, bladder problems, which can present as interstitial cystitis, urinary urgency frequency, feeling like you have a UTI or prostatitis, but you keep coming back with negative infections. Um, negative infection, and then, we also, of course, see the incontinence that you hear of, constipation. As you know, the muscles surround the rectum, so if it's really restricted, it can kink the rectum and then create difficulty, with bowel movements, and same thing with intercourse, like, these muscles surround the vaginal opening, and they also surround the penis, so they can create some penile pain, pain during penetration, etc. So, and abdominal pains, it's all connected, back pain. Yeah, and so, yeah, that's it.
Okay, no, thank you so much for and I love the visual, that's, incredibly helpful for people that are watching. Now one of the reasons I wanted to have this conversation is because of the patients that I see in rheumatology,
Mhm.
and some patients that I see have chronic low back pain. And it sounds like it may be suggestive of inflammatory back pain. They describe a lot of stiffness in the back in the morning, pain that improves as the day goes on, as they start to move, pain that may wake them up at nighttime. And we check their labs. There's no evidence of inflammation. We check advanced imaging, including MRI, and there's no evidence of sacroiliitis. And so my question is, what pelvic floor related conditions can contribute to persistent low back pain, perhaps in someone that like I've described, or a side joint pain, and that may sometimes overlap with this presentation?
Yes, so this is very multifaceted, and we can go over how we evaluate and treat.
Mhm.
But some of the things that we do start with is an orthopedic evaluation. So we are looking at how the sacrum rests in the pelvis, if there's any obliquities in the iliac crest, ischial tuberosities, if there's any rotation of the sacrum, because that can, as you can see, if there's like a slight rotation, it can be pulling and straining on different nerves, blood vessels, ligaments, and muscles. So that in itself as creates pain. Um, for example, a big orthopedic example is that when people give childbirth and vaginal birth, the pelvis does need to nod forward. The sacrum needs to nod forward so that the baby can come out and it creates extra space in the perineum, right? But sometimes, like the sacrum is a little bit stuck in that sacral flexion position, and look at how much it stretches these muscles out. So that's just one thing that we can look out for is just the positioning of things. Of course, like the nerves and blood vessels would come from this area as well, and then to the pelvic region. So it can create some nerve dysfunction as well. Um, when we're thinking about uh, other conditions like interstitial cystitis, endometriosis, we are considering, or even constipation, we are considering how the viscera moves in the body as well. There is something called the visceral-somatic convergence or visceral-somatic reflex, which does sound a bit fancy and complicated, but if you break the word down, visceral-somatic, you have the viscera and then you have the soma. The viscera is the organs. The soma would be like the skin, the fascia associated with those viscera. For example, let's say we have this bladder, right? The bladder has it well, it's innervated by nerves and it then goes to the spine, right? The spine in that same region of the spine, it also innervates muscles, fascia, and the innervation converges on the same spot on the spine. So your brain can, when these signals go up to your brain, brain can confuse it as a bladder problem when it's really like a soma problem, or a soma problem when the bladder is a little bit irritated. And that can create some dysfunction in the fascia, decreased movement, decreased blood flow, and ultimately, like, movement and pain can come from that as well. Hopefully I made sense with that. Yeah.
No, that's incredibly helpful. You have such a meticulous understanding of the of anatomy. I think that is really where, for people that are listening, is that it is what one is experiencing externally symptom wise. There's so much. Maybe that's like tip of the iceberg, as I'm understanding it. There's just so much else that you're exploring and understanding specifically about their anatomy that
Mhm.
can help them to understand those symptoms. So that's super helpful. Thank you. So for someone that's living with chronic low back pain, what symptoms or patterns would make you think the pelvic floor may be contributing to their back pain? You kind of touched on this as well.
Yeah,
Mhm,
yeah. I was, like, preparing for this interview, and I was quickly looking up some studies, and I know that this is, like, a very small study, but I wrote it down here. It was 85, females with low back pain. The study was in 2018, and of the 85 people, 95.3% have pelvic floor dysfunction,
mhm.
which is extremely high. I know it's a very small sample size, but if you break down the concept of how the pelvic floor works, it truly does make sense. So you have the pelvic floor at the bottom of your carriage. It's at the bottom of your pelvis, and it acts like a hammock at the bottom of you. So that's part of your core. Other parts of your core would be your abdomen in the front of you, the diaphragm on top of you, and your back muscles in the back of you. If any one of these core muscles is a little bit dysfunctional and not stabilizing how it should be stabilizing, etc., then it can create dysfunction in the other muscles. So, for example, if you have low back pain and there's like some stiffness there, weakness there, it can create some overcompensation of the pelvic floor, and other things. That's just one example.
I see. Yes. No, thank you. Now walk us through the initial pelvic PT evaluation. So let's say a patient with chronic low back pain is referred to you. Walk us through the initial evaluation. What should patients be expecting?
Yeah, so I like to think of our clinic as very friendly. It could be a very intimidating situation for people to be in when they find themselves in my office, but we try and make it as comfortable as possible. So it starts as a conversation. Um, how did your symptoms start? Uh, what are you experiencing now? We go through, even if it does seem unrelated, we do ask about bowel, bladder, and sexual function. As they're comfortable, we'll ask about those because it does relate with each other.
Mhm,
And yeah, so after the subjective exam, we'll go through a short or orthopedic exam as well as a pelvic examination, which is we're looking at their abdomen, lumbar, lumbar spine, diaphragm, and then if the patient is comfortable and gives consent, we do an internal evaluation, which is transvaginally and transrectally,
mhm,
where we assess the pelvic floor muscles.
mhm. I see. No, thank you. Now, once you identify that there's pelvic floor dysfunction, what does treatment typically involve? So can you describe some of the approaches you use, such as exercise, mobility work, breathing techniques, etc.?
Yeah, so we do, all of those things.
Mhm.
So we do, manual therapy. We rely on manual therapy specifically for the pelvic floor, mainly because almost every other muscle would cross a joint. Like, for example, if I wanted to stretch my bicep, I would just lengthen my elbow and then we'll get a lengthening of the bicep. However, as you can see in the pelvic floor, it doesn't cross a joint, it's just a hammock. So you would have to rely on breathing strategies or manual therapy to then release and stretch these muscles and then we'll figure out different motor patterns to uh, help facilitate that in your home program as well. So that's pelvic floor specific, but then there are other exercises that we can do, whether it's relaxing, lengthening exercises versus strengthening stability exercises. And because we do know that there's a strong lifestyle component to this, we're also looking into how a person's eating, sleeping, fluid intake, things like that.
So do you give them exercises to do at home, like a regimen?
Yeah.
Yeah.
Yeah. Like, for example, let's just say, somebody is coming in with interstitial cystitis or they feel like they're having a chronic UTI. Those patients typically have, an hypertonic pelvic floor, increased tone of the pelvic floor. So, we then start with, like, the manual therapy and the abdominal pelvis, making sure that they know how to relax the pelvic floor. Some of the quote, unquote, "exercises" could be using a Therawands to stretch the muscles internally themselves,
Mhm.
exercises, and eventually some stabilizing exercises so everything can hold in place.
And would it be, like, every day, Rachel, or, like, is how many days a week? I know I imagine everybody's individualized, like, in rheumatology, but what's, like, a typical day? How many days a week do you generally advise for the exercises?
It really depends on the exercises. For example, let's just say somebody has um, a heightened nervous system,
Mhm,
highly anxious, very, very stressed at work. Part of the pelvic floor is 25% innervated by the autonomic nervous system.
mhm.
So those exercises, which would be like diaphragmatic breathing, being aware of how you're holding tension in your body, that exercise could just be mindfulness throughout the day. If you're holding your breath, if you're, like, squeezing your glutes, grinding your teeth, it's that stuff is more reflexive and awareness of what your body is doing throughout the day. But if, like, the physical exercises, they could do it every day, every other day, and sometimes less throughout the week if they're just maintaining status.
Okay. This is incredibly enlightening because if you think of how many people have low back pain, and like our medical teaching and our learning, it's like, just like bread and butter what we see. And everybody at some point in their life will have low back pain. And
Mhm,
it is really I feel like it's sort of it's changing my practice and how I view and where I may have, perhaps gone the medication route, like in these individuals that I discussed, where it sounds like the back pain's inflammatory. Rheumatology is also complex, so,
mhm,
sometimes I do end up, even if the imaging is normal and the labs are normal, but I'm really convinced based on history that their back pain is inflammatory, I may initiate immunomodulating treatment. But now that I've really understood personally more about what you do and more of what, how your lens is viewing the same symptoms that I am modifying where I am having people now, as you know, come to you to really get this assessment and have at least several months. And we'll talk about this in a moment, but
mhm,
at least 3 months or so of work with you to identify, is this a pelvic floor issue that they could potentially not need to be on
mhm.
medication if it's possible. So thank you for going through all this. Now, transitioning into recovery. So some people may not know what to expect or how long treatment will take. So what does a typical treatment course look like? Can you walk us through that?
Yeah, so we typically go through what we call the pelvic module. It's
Mhm.
like 3 phases. For the first phase is educate, which is, we're pretty much learning about, the patient's body with not just I know the first visit is called initial evaluation, but we continue the evaluation to the subsequent visits because there's just so much to go over and learn about each other and how the person responds to touch, responds to movement, and any of the home program that we do assign. Um, and in that phase where we're just really lengthening a lot of the structures that do need to be lengthened, then we move into the enhancement phase where we're reintroducing how to contract the muscles properly, use it in a non-painful way, and then the execution phase, which is we return back to sport, return back to exercise, which not all the time is back to sport or exercise. It could just be working from a computer because you have to sit a lot, or um, getting intimate with a partner again. So that's in a textbook case, it is a lot of the studies are based off of 12 weeks.
Mhm.
So 12 weeks is our baseline. Yes, some people get better a little bit before that. The more chronic the pain is, the longer it is expected to be in therapy.
Okay. No, I think that's really helpful for listeners to at least have some framework of 12 weeks, 3 months of just if I put the work in and I'm a cooperative partner with you, then that at least gives them some guidance. So thank you for that. Now, from your perspective, when should a rheumatologist or other physician consider referring a patient to pelvic floor PT?
That's a really good question. As we know, or we just discussed, a lot of people who do have back pain do end up having some sort of pelvic dysfunction. But what would raise really big red flags to be like, go to pelvic therapy is if it's associated with some of the other things that we had discussed. Like, for example, like the interstitial cystitis symptoms, urinary symptoms, bowel symptoms, pain with bowel movements, constipation, even fecal incontinence. Pain with intercourse is a big one.
Mhm.
I know men don't, we really don't hear men having pain with intercourse, but what we see often is either erectile dysfunction, premature ejaculation, or pain in the penis after ejaculation that lingers and feels like prostatitis. Things like that would be red flags to then go to pelvic therapy. And even, like a hard fall on the tailbone would
Mhm.
um, would be a good reason to think that the pelvic floor could be involved because the pelvic floor muscles do attach in that tailbone.
Are there people that you evaluate that you don't feel have a pelvic floor issue? Like if they come to you with pain and you say, I don't think that the pain is coming from your pelvic floor?
There honestly, there are some cases, where it is more of like a central sensitization issue
Mhm.
or a more widespread rheumatology issue
Mhm.
where the pelvic floor may be secondarily involved, tertiarily involved, but that's not the why. Um,
Mhm.
it could be affected, but that's not the whole reason why somebody, is in a lot of pain. So those examples would be something like fibromyalgia, EDS. We can really help those patients in their pelvic floor symptoms.
Mhm.
However, then we're starting to think of sending to a rheumatologist.
Mhm. Yeah, and I think that I always mention too for people that are listening that sometimes people can have more than one process happening simultaneously, and so I always mention that because it truly is complex assessing pain sometimes. So I think that is also important to know. So now, Rachel, what's the one thing you wish every patient with chronic low back pain understood about how pelvic floor PT may help them?
Yeah, I first, I hope that they know that we exist.
Mhm.
I hope that we know that we exist. A lot of people do find success in regular physical therapy or chiropractic care or some other form of body work, but not many of us do specialize in the pelvic floor, and that can be the missing link. Um, and not to be ashamed to ask for help because it could be a very sensitive topic. We are doing things that would make someone feel uncomfortable. However, the professionals are very professional, and we make you
Mhm.
feel as comfortable as possible, and if you need help, like, it's not, please don't be embarrassed about it
Mhm.
because it's so many people go through pelvic dysfunction. I think it's 1 in 3 people in their lifetimes will experience some sort of pelvic dysfunction. It's not weird. It's just a part of your body, and, the less we associate shame with a body part, the more we can get help for it. Yeah.
Mhm. Yeah, no, and I like that your statements are really normalizing that this is and I really like the way that you're sharing. I wanna share too from just a medical doctor perspective that we do see people that have, like chronic abdominal pain and chronic hip pain, and I liked when we met, Rachel, that you shared that pelvic floor dysfunction can people can manifest symptoms anywhere from like the diaphragm to the mid
Mhm.
thigh. I think that whole area. I think that was a light bulb moment for me because certainly we see patients just throughout our career, just from the medical perspective, that have like chronic abdominal pain that they've had just every medical workup under the sun, and there's nothing there. Like they've had
Mhm.
scans, they've had labs, they've seen experts, and they're really suffering. So I think for those people, for people that are listening, if you or someone that you know may be navigating through just that pain in that vicinity, diaphragm to the mid thigh, as you shared with us, Rachel, that I think it's really important to know about pelvic PT and to really to consider that as a resource. Now, Rachel, thank you so much for joining us today, sharing your expertise so generously. Now, we touched about one of the most important messages I hope our listeners take away is that chronic pain is often complex. And understanding the source of pain is an important part of finding the right treatment. And as rheumatologists, our role is to identify inflammatory conditions when they're present. But also, we want to recognize when there's other contributors that may be playing a role. And so, for some patients with chronic low back pain, hip, pelvic, or SI joint pain, pelvic floor PT may be an important part of their care and journey. Thank you for joining us on Everyday Room. We hope today's conversation provided helpful information and encouraged you to continue advocating for your health.
Thank you for having me.
Okay.
Thank you for listening to another episode of the Dr. Raj podcast. If you enjoy the show, then please make sure to follow us on your favorite podcast app and leave a rating while you're there. This show is for educational and entertainment purposes only and is not intended as medical advice. This has been a production of MedPrep2Go, and you can learn more at medprep2go.com.